Well, good morning, everybody. My name is Christian Malaster. I'm the CEO and founder of Ingenium Digital Health Advisors. I see some familiar faces here that have been here through some of the presentations the past days. I've really enjoyed being in person again here and connecting with people, and I'm always amazed by the caliber of the presentations that Kathy Beverly and her team put together, and the caliber of the attendees. It's really, really great to see so many people who are so passionate about it and have accomplished so much, especially during the COVID-19 crisis. And also nice to see some new people here. So telehealth is all about being a clinical tool. And so I'm very pleased to have my colleague and friend, Dr. Matt Feynman here to talk about telehealth and telemedicine. As you know, it's a major tradition to not read the bio. So if you want to read more about Matt's background, go to the app. We also have some polls. No, actually, in this one, we don't have a poll, sorry. But you can see his slides there as well. And without further ado, Matt, thank you very much for joining us here.
Well, thank you, Christian, and thank you everyone for joining. I want to just make sure, as I often do in a video visit or virtual visit, some of my sort of checklist personal things. So want to make sure everyone can see and hear me okay. And if the thumbs up. Good. All right. See, this is sort of like the part of the website manner 101. I don't want to steal away from my own slides, but these are some of the items that are relevant. I really appreciate the honor and privilege to be here today at Matrix to speak. And, having already joined some of the conferences from a distance, and seeing some of the comments and seeing some of the highlights so far have really been interesting, stimulating, and exciting to see where everything is going in terms of digital health, digital transformation, and the tools of how we're going to change healthcare. And in my way, I always wanted to take away the word tele and just put healthcare and leave it by that, because I think that's where we're all trying to head towards. I'm privileged today to speak to you around leading physicians toward excellence in the delivery of telehealth. I would probably even rename this as leading clinicians or healthcare providers toward excellence, because I think this sort of is something that is important for all of your healthcare team. Understanding today that the audience may be a mix of both clinicians and non-clinicians, administrative and others from different spaces, I want to provide you some ideas, perspectives from someone who's worn different hats. I've been a practicing internist for over 20 years, but also someone who's been passionate about telehealth and more in that hat as well. And so I understand and recognize that there's a lot of things that we're all doing at the same time. So I want to get into this and get into the details and create some opportunities for some Q&A as well. In order to get there, though, I need to get through this screen, which is the disclosures, and I will read it as is. I have no real or apparent financial relationships that may create a conflict of interest to disclose. Now that all of that legal mumbo jumbo is cleared up, what I really hope to accomplish today is threefold. Is an overview of virtual health and virtual care. For many of you, you obviously know this, but it helps for me to provide a framework. Honestly, some of these slides are not just designed to be in a presentation format. I actually use many of these slides for the onboarding tools for the providers that I work with closely, because I think it gives you high level. Also, I want to speak to the tools that are necessary to build a successful telemedicine program. And finally, the fun part, I think, for me is that interactive piece that sometimes people forget about, and tips and tricks for telehealth visits, which is important and critical for the success after many years of seeing it not be done as effectively and as efficiently as it could. So some of the key points around how to build a telemedicine program comes to four entities, four areas. It really helps from a strategic alignment piece if you have leadership support, especially from the executive C-suite in your organization, but also it's important and imperative to have governance and a governance structure set up. And as you'll note, the governance can't just be internal to your own department in telehealth. you really need the full comprehensive approach from multiple departments: operations, medical operations, IT, marketing, legal, everyone in between, because really you are creating tools and use cases for how telehealth will be delivered across the organization, and you really need to have it accepted and become part of the day-to-day. So that's really critical. And I found this really came to light during COVID, but it was already in play beforehand. Having a handbook really is that go-to. I have a handbook still sitting by my side here. I refer to this frequently. It's helpful for training and onboarding. Providers like something tangible still in their hands for all the digital things that we use with apps and everything else. It really helps to have something that you can refer to, where your workflows can go, where your troubleshooting tips and tricks can go, and where people know there's a resource that they can refer to. And with that, you can create, and it's important to create clinical care guidelines. This should come internally from a team. It doesn't have to come, from the leadership team only. It actually helps to have as a team building exercise, to have providers from all areas, APPs, physicians, nurses, others who are involved in care delivery, to help create sort of care guidelines, because having those guardrails set up really provides sort of a peace of mind approach for what providers need to do when they need to escalate care. And finally, quality framework. And I'll get into some specifics around what we've done, both when I was at Cleveland Clinic and where I am now at NextCare Health, where we are using some of these tools to build and escalate some of our quality tools. So setting the stage here, we all know that we are very consumer focused and patient centric and patient focused, and we really have to think about that. We are in an evolving competitive landscape, and sadly, in some ways, healthcare has sort of lagged the rest of the service industry in some ways, yet we're starting to catch up. And we have to meet our patients in the middle when it comes to preferences for convenience and cost. And access to care has been a real challenge, both in the rural areas, but also across the board in academic medical centers. And providing a way for patients to, eliminate barriers to care, notwithstanding some challenges around digital divide and other things. It is a way to provide efficiencies to your clinicians to deliver care, to optimize care. And also, as we moved from volume to value, we have to think about optimizing outcomes and providing some of those clinical, research around how to be better at delivering a continuity of care and early interventions. And finally, some of our areas where I live in Northeast Ohio and others live, some of our markets are very dense and the competition is really, really tight. And if you really want to think about growing your market share, adding telehealth, as you think about it, both to your local markets and your direct to employer and health plans, is really a good and convenient strategy as you build out programmatic development. Now, we have to think about this because there's such disruption going on. It's sort of uncomfortable every day, every minute you turn on your phone, you read something new and you're like, what next? And it's been like that for some time. And, I have lived in academic medical and we sort of insulate ourselves figuring we don't know about it, it won't happen. But the reality is the payers are starting to deliver directly to their own membership. Walmart has started to do this on its own. CVS Minute Clinics have been around for some time. Optum is doing this quite effectively. And obviously, we know what Amazon's reach is like, and they themselves are starting to do virtual first for so many of their options and for their membership, that it really puts the disruption on us to think about being better at doing and delivering care. So if we are going to move forward, it always takes, it always helps us to take a moment and pause and learn from the past, because, I laugh and smile about all of these rules and changes that are happening in telemedicine and telehealth, especially vis-a-vis audio only, telemedicine reimbursement. And if we look back, telemedicine and audio has been around for, 150 years. We've been using audio only for a long time. It's just how we've been building it into our practice. And in fact, if you look back 100 years, the father of science fiction, Hugo Gernsback, had this idea of a radio doctor where a patient would sit in front of a television screen and speak to a healthcare provider. This is not much different than what we're doing now, and yet it was there over 100 years ago, which is quite remarkable, all things considered. And then you can fast forward into the 60s, where you had Logan Airport with Mass General Hospital doing sort of a version of what many of us consider to be, telemedicine, telehealth. And then we have to just sort of bring into the future this curveball that came along, which was, COVID. And that just sort of disrupted everything else. And so we have to respect the past if we want to move and be thoughtful about the future. Now, for me and the team I work with, some of the things that we thought about was framing this, and it helps particularly for your own team in the organization. And by team, I mean not just the clinical team, but you have your front office, your front desk, you have non-clinical people in marketing and IT and legal. They hear the term telemedicine, telehealth, virtual care, virtual visits. You can keep going on with the interchangeable terms. And if you don't set it internally, what terminology you want to use, this is my framework that I, have worked at for a bit of time of how I like to frame it. And this is a common way of thinking about it. But if you don't share this, patients may ask for a video visit, and the front desk may say, oh, no, we only do telemedicine. That's not the same. And then they don't offer it. And so you really have to be thoughtful about what you do within your organization if you want this to stick. And so this is sort of the, telehealth is healthcare at a distance, and it encompasses telemedicine and teleeducation. Like Project Echo would be a good example. Under the telemedicine strategy side of the equation, we would have obviously the synchronous and async stuff that we all are familiar with. So just keep that in mind. And then the quadruple aim, I bring this up, the Institute of Medicine had the triple aim in healthcare, added the quadruple aim because it wanted to include the fact that you need provider satisfaction, and happy providers and happy patients makes for happy healthcare systems, because you can deliver better outcomes at lower cost, and it just makes economic sense. We heard a discussion yesterday, I think it was at the noontime, around you need evidence to support some of your systems, why people might want to invest in some of these apps and other areas. And I too like to point out to my providers that we aren't just trying to push things down them. We want to make sure that it's successful because we are thinking about their own satisfaction as well. However, we are involved in what is now the modern healthcare consumer. And the consumer definitely votes with their feet. They have a smartphone for the last, almost 15 years, and they think about convenience, value. They will jump ship. They will move PCPs. I've lost patients as a PCP over the years because my access wasn't good on some days of the week. And the patient said, I can go over to the doctor in your practice or a doctor down the street because that was more convenient and I wanted to take care of my issues. So we really have to play this balance carefully if we want to be successful in creating value and understanding, at least from a standpoint of consumer satisfaction and then provider satisfaction. And then a couple of personal thoughts, and then I'm going to jump into some of this, the nitty gritty of the pieces that make physicians feel more comfortable. So we all know about the changes that happened in March of 2020 when suddenly we all have to make some concessions with the pandemic. And when CMS lifted place of service to allow the origination site to include home, that sort of like was the angels were singing and the aha moment came. And that really allowed for a lot of expansion almost immediately. And I also point out to the clinicians, and this one I spend a bunch of time on, that not every use case is a one-for-one. So when your office is thinking about offering visits to patients, not every congestive heart failure assessment can be taken care of virtually. Not every sinus infection, not every chest pain, not every shortness of breath lends itself. And so there has to be a common sense approach. It comes back to that idea around having guidelines. And if you do have them, then your team at least knows, well, if the patient's really going to need an EKG or a patient might need this, we probably should just have them come in person because they're going to be escalated anyways. On the other hand, there are many symptoms that really lend themselves, and triage can happen at the front door, your digital front door with your clinicians, and allows for evaluation where oftentimes patients might defer care. And so it really is that, yin and yang of how to approach things. By the same token, the light has been shone on telehealth for a long time as it being inferior care when it comes to things like sinus care, upper respiratory infections, bronchitis, and overprescription of antibiotics. And as a person who's involved intimately in quality, I understand where that challenge has come from, and it's sort of been a persistent reason why my team and I have been at this for a long while. About we want to make sure that you're going to compare apples and apples when the time is right, but at the same time, you want to realize that there are times where telehealth is maybe superior to the standard of care, which is ambulatory, ER, urgent care, primary care, because there are some recent studies suggesting that telehealth actually is maybe more cost effective for delivering care when it comes to, let's say, ankle pain, because we are less likely to order x-rays that are unnecessary. So there are instances that you can provide evidence, show support, measure things, and then show your cohorts, particularly your clinicians who may be a little uncertain about what they're doing, that this actually has value. And then finally, we all understand that the public health emergency and the waivers that go along with it are going to expire at some point. And though they've, kicked this down a little bit, another few months into July, plus, maybe another 151 days gets us to the end of 2022. There is definitely uncertainty. And this has been a discussion for all the clinicians I work with around what rules will stay, what reimbursement may go, what is unclear, what's going to be there. And it has to be an ongoing communication if you want to have the providers stay engaged to the care. So providers know that there's value to this. This is I want to just move along through this slide. We obviously know that providers who want to have hybrid lives, and this, this Matrix 2022 is a perfect example of hybrid meeting where you have someone like me who's at a distance, you have people in the at the presentations there today. There is a value for some who want to have balance and work-life balance where they can actually see patients from anywhere, which is really convenient. But I also remind providers that you need to be in the shoes of your patient and have more empathy if you want to understand what they're going through and the vulnerability that they often have and face when they come see you. And so thinking about their experience from their perspective also will help you guide them through their experience when they're coming to see you. So some obvious things that patients and things that resonate with patients include skipping long lines, avoiding the waiting room, appointment from home. Infection control was the obvious one. We did this with flu, 5 years ago. Obviously, COVID lends itself as an assessment tool for patients who can be screened and assessed, and you reduce the risk for the clinician, you reduce the risk for the patient to spread illness. So it's very easy and quick access. So one of the tips that is very helpful to prepare a patient for their visit, like what to consider before your visit. I remind patients that having a telehealth visit is sort of the idea of be prepared. You come to your in-person visit, your brick and mortar visit with some expectations. You plan, like, why am I there? It's a follow-up for my diabetes, or I'm sick today and I think I have a sinus infection. Sometimes we see patients who come ill-prepared for their visits, even though there's instructions and there's an idea that you should use some technology and having a good camera and preferably using some form of a digital tool like a mobile or a tablet. I put down here a two-way street. And what do I mean by that? Here I am with this, I've downloaded this background, which, unfortunately, the more I move, the more you see the ghosting behind me and the pixelation. So it may not be my preferred background, but it's as professional. I sometimes would wear a white coat to see my patients. And yet patients come to see us in all sorts of situations. They're driving their car down the interstate and I have a seizure every time they drive by a sign or go by a light, or they're in a stairwell at their office, they are in their bedroom, they are in some strange location, and we all smile as we reflect on this because this is not uncommon. And yet they expect us to be able to diagnose this strange looking rash where the lighting is poor, everything is suboptimal, whereas if they came to the clinic, they would put their arm up right up to the camera and we would get a pretty good view of what we're looking at. So that's the two-way street that I make sure that patients understand how they can optimize the visit. The other piece is, telling the patients to find a comfortable space also works for the clinicians. Locating and checking the links, understanding if there are costs to the visit, realizing that just because you have insurance doesn't mean it's going to cover the visit, and some have such high deductible health plans that it's a barrier. The patients may choose to opt out and no-show just on this piece alone. So again, reminding the clinicians, like, why are your patients having struggles? Maybe it's around that piece. Accepting the type of visit that they have is an understanding of this may be different. This is novel to the patient, and that it is different experience. You may have done 1,000 of these, but the patient may have only done 1 or 2. And so it can be stressful. The other thing is that you want to make sure as you have the patient check in that if they have the ability to collect vital signs from their remote device, make sure they do that. If they have blood sugars, blood pressure, blood oxygen, that they can do all of those. Also having the follow-up appointments are really, really helpful for a lot of patients because they feel like there's a disconnect at that piece. So what about preparing yourself for the telehealth visit? Excuse me. So this is sort of the fun part, and it's the moment of truth, as I would like to say. When you get connected, besides the fact that I call it the housekeeping piece, where I say, good afternoon, Miss Jones, my name is Dr. Feynman, and welcome to your virtual visit. I'm going to go through a couple of housekeeping things. And when I do this, i.e., make sure I have the right patient, the right name, the date of birth, and their demographics, and their location, and their consent. By doing all of that, I'm also in immediate assessing their body language, seeing if they're in distress, seeing if they're coughing or wheezing. I can also assess their surroundings, because one of the things that is really important is normally in the past, I would knock on the door, walk in and shake the patient's hand. Obviously that changed with COVID, where we now do the elbow bumps. But even so, it is very difficult to do the standard handshake to establish rapport. And you can only do it by a few different ways. One of them is making eye contact with the patient, and the other is to sort of talk to the patient about maybe something common or something that sort of ice breaks the situation. And in many cases, as you look at their surroundings, you may see on the back wall that they have a placard or a football item or some sporting goods, or maybe they're traveling. And on the balcony, you notice that, they're actually on vacation and you can see the ocean, and you're totally jealous that they're in Hawaii and you're not. And when you see that, you comment about it and suddenly it puts them at ease. And this is a good reminder to clinicians who don't have good bedside manner, like, these are some basic checklist things that you need to do in your mind to make the visit go smoothly. Has nothing to do with history taking or diagnosis or anything, but you will have a much more successful visit by doing that. And you see, I haven't even talked about like walking your patient through the physical exam, which we'll get to. It's important. Taking your time, acknowledging the surroundings and novelty. Again, this may be your 1,000th visit, but it's the patient's first or second one. And so realizing that, hey, we're going to accomplish a lot today, and it may not be in the office like the last 20 visits, but we're going to discuss your chronic health conditions and get through a whole bunch of things today. And we're going to make a plan of care, and we're going to make sure that you have a follow-up appointment by the time you're done. So the patient then gets an expectation around what's happening. Those end up being very invaluable to the patient's experience. Now, these have been highlighted elsewhere, and I don't want to get too much into it, but some of the things that are just to highlight here is the hard part for a lot of patients is how you, and providers, is that eye contact. So you'll notice that Hollywood notes that the camera adds 10 pounds. I note that the camera is a real problem for people who have poor, bedside manner, because they don't like looking at the camera. They tend to look down. They talk to people this way because they're too busy on their keyboards, looking at multiple things. And then they end up doing a lot of what I'm doing right now. I'm looking between multiple screens. One of them is the camera for the patient's video visit. The other one is the EMR. And lo and behold, the patient doesn't know what you're doing. You haven't told them. And it makes for the patients, as they're describing their issues, looks like you're shaking your head no, like you're upset with them. The point here is that there are a few elements of describe what you're doing, because they can't see what you're doing, versus if they were in the office, they would see that you're looking at the screen, then you're talking to the patient. The patient may be sitting next to you in the office. That's a little bit different than when they're sitting at home having the virtual visit. So those are very important to make for a better, successful experience. And obviously having a HIPAA appropriate space. I say choose your home office wisely. As we all know and have heard about Zoom bombing and those nightly newscasters where suddenly the little child comes zipping in through the corner and then the spouse comes running in to try and save them, and it only adds for some fodder on YouTube for everyone to enjoy and everyone to sort of share on Instagram. So we don't want that to happen to you. We want it to be appropriate. Now, the meat of some of this is on the physical exam. And there's a lot of things here that I think I'd like to highlight. Firstly, why do we care, and can you perform a physical exam? Yes, you should. And why? Well, physical exam itself allows for observation, description. It may add up to 20% more besides the history, which in many cases, 80% of the time, we get a diagnosis. But it does help, especially as AHRQ and NQF, National Quality Forum, and others have shown us, especially when you escalate care. So if I see a patient today for an acute issue and I see that they are not coughing, they're able to complete full sentences, they're not wheezing when I ask them to take a deep breath in and out, and I write that down, but now 3 days later, they come back to see me or maybe someone else in the care team, and now they are coughing incessantly, they are unable to complete full sentences without wheezing, they look in distress. That is a completely different examination and a completely different assessment from where they were. And that one line that you wrote in your assessment and physical exam makes for a hugely different approach for that next visit. So it does add value. The other piece around value is there's an expectation when patients come to the visit, the doctor's visit, the nurse practitioner's visit, that you're going to use your stethoscope. And obviously we don't have stethoscopes. We've seen from some of the vendors that yes, there are some vendors out there that have devices that patients can record their heart and lung sounds and look in their ears, and that will be very much in vogue and coming to a store near you. But until it becomes ubiquitous, for the time being, we have to do a physical exam when we do virtual visits because patients expect it as part of the, sort of like the transaction of doing a visit. So whether you have them press on their sinuses, stick out their tongue and say, ah, and they giggle because they're like, this is so strange that you're doing this. How are you able to look at my throat? Or any of the above, that piece of it is a perception of value. Even if that may not help with your diagnosis, it does have a perception of value, and that makes for difference. And in the terms of reimbursement, yes, there are some changes with the AMA guidelines from 2021 about timing and what we can bill for, etc. I still think it's important piece to have built into your templates of how you document, because physical exam is helpful. This 10-step checklist is also a placeholder that I spend a bit of time on the onboarding with my team. Benziger et al. Last year pointed some of these out, and this is good. Many will just print this out. And I mentioned to providers that you don't need to collect all 10 with every visit, but if you need to focus on one versus another, it's very, very helpful. So for example, you may have a rash of a patient, sore after they were out in the yard on the weekend, cutting the grass and pulling some weeds, and suddenly they have, very, very itchy rash localized on their upper arm, and it is consistent with poison ivy. And so, assessing the skin may be the only thing you need to do. Whereas vital signs, if a patient has a remote device, they may be able to get their remote blood pressure and pulse ox and temperature and provide that to you, because that may be essential for your determining what the nature of their illness is. On the other hand, when people see conditions such as abdominal pain, it's like hands off for providers. They have no idea what to do. And to be fair, I will have patients stand up, me included, and I will describe what to do with my abdomen. I break it into 4 quadrants: the right upper, the left upper, the right lower, and the left lower. And I will have the patients take their hands and press right below their rib cage and press with firm pressure, and then describe what they feel. And it's not the same as obviously me examining their belly. If they're able to press with firm pressure in all 4 quadrants and have no discomfort, it doesn't for sure prove that there is not an acute serious process. In fact, I may have the patient jump up and jump down 3 times in front of me, and if they do not wince, they do not display any discomfort, the likelihood that they have a serious condition that warrants emergency room evaluation for some imaging is very, very low. And that is reassuring. So again, knowing where you can pinpoint the physical exam for the assessment at hand is really, really critical, and making sure you document it. I will point out a couple more in the next couple of slides. So here is another evaluation that I think highlights a few things. First of all, when possible, make sure that your documentation has things like, if completed, performed via video-enabled technology. Why? Because in some EMRs, they don't discriminate where the examination is coming from, like vital signs, etc. So if you write down the blood pressure that the patient shares with you, it may look like it was from the clinic. And as we know, that needs to be notated, whether it's coming from a home blood pressure or whether it's coming from an in-clinic. So that's important. The other thing is, things like, note findings per patient. I put in a link here about respiratory exam and tips. I put some pictures in here for one specific reason. When you are demonstrating something to a patient, they feel much more engaged. And so I will have patients press on their sinuses. If I told them, please press on your maxillary sinuses, they're going to look at me blankly like, well, where is that? And they don't know that you have frontal sinuses and maxillary sinuses. And if people say I have a sinus infection, that may have different meanings to different people. And so describing by pressing on the bones up here, your facial bones, with firm pressure, almost like you're trying to break them. It sounds like very significant for what I'm saying, but otherwise patients just kind of press lightly. Oh no, there's no pain. That doesn't help with the determination of what you're getting at. And I realized that the HEDIS guidelines and the NCQA guidelines around sinusitis doesn't require there to be tenderness like this, but it does help confirm sometimes or rule out that there's something more serious going on. By the same token, we use criteria for strep throat or sore throat, about whether a patient, adult or adolescent or pediatric patient, has strep throat or whether they need to come in. And we use Centaur criteria. These are validated, evidence-based criteria. The higher the criteria, the more likelihood you have strep throat. Well, one of those criteria involves the glands in the front part of your neck. So you can see here in the pictures, down over here on the right-hand side, if you have the patient feel in the front of their neck and describe what they feel. Do they feel marbles, bumps that are the size of golf balls, grapefruits, etc.? They're firm, are they tender, or none of the above? That helps you, because that may reduce the criteria, or reduce the number of criteria and their Centaur score, such that you can comfortably say your risk of strep throat for your child is 5 to 10% versus it might be closer to 30 or 40%, and we need to now refer you in for a strep test. So again, Very helpful tools here in terms of strep or the need for further testing or further referral. Now, this is a lot, and the design here isn't to overwhelm you, that you can write a lot of templates for physical exam, which may not even be looked at by your coders and billers, but it's helpful to point out that half of this is all neurologic. And I put this in here because many providers, physicians, and others shy away from, chief complaint of dizziness, vertigo. Heaven forbid you come to a virtual visit with vertigo and no one knows what to do. And you can do a lot. You can almost do a complete neuro examination via telehealth. You can get the cranial nerves. You can have patients come in really close to the camera and look to the right and look to the left. And you can see if they have what's called nystagmus, where the eye socket, you'll see the eyes kind of twist and turn on their own as you have them move their eyes from right to left. And this may be a clue to an inner ear problem, especially in the right history context. And you may have them, I think this part is fun for me. I actually, traditionally we would have patients touch their nose and then touch the finger of the provider. Instead, I have them aim it out to the camera lens. And if they're holding their smartphone, they'll do it just like this. But this will tell you sometimes if they have a tremor, especially if you see them shaking their hand, if they have a problem with alcohol withdrawal or if they have a problem with some other neurological condition. So these are all very helpful. And we always forget, before I move on to guidelines, getting people to get up out of their chair. Like once we feel sort of like stuck, once we get into these visits, I will have people happily walk. I will have people take their cameras and reverse the screen camera so that I can see the distant lens and have them shine it down so I can see their ankles. I will have them press on their ankles with firm pressure for 5 seconds to see if there is swelling, because it will help if someone says, I think I'm having a congestive heart failure episode because I've gained, I went to the rib cook-off, I ate 4 rib slabs and maybe my blood pressure is up a bit, maybe I'm retaining some salt. It helps strengthen the case if they don't have or they do have quite a bit of swelling, which is new for them, and it might allow you to figure out what to do. And with that, are there guidelines? Yeah, there should be, there can be. Ironically, from a national standpoint, the Infectious Disease Society of America, the American Academy of Pediatrics, the American Academy of Family Medicine, and the ACP and others, a lot of their guidelines are around conditions, and they were all designed with brick and mortar in mind. And telehealth guidelines have to be done probably at your own academic medical centers or own ambulatory centers or anywhere. But they provide best practices, and they definitely help because they provide those guardrails for what you can do when you need to escalate care. And they're helpful for quality, which I'll get to in just a second. And so some examples of some guidelines, we have ones about lighting and how to set up your backdrop. We also have things like obvious or not obvious ones. They're ones around the virtual health guidelines of depression, anxiety, and how to handle some of those chief complaints, down to what do you do when your EMR goes down? What do you do when your VPN goes out? What do you do when the tech challenges, which gives patients and providers like 20% of their sore spots still is around tech checks and tech issues? Or what to do if you have an emergency is not commonly thought about, but what happens when your patient is sicker than they should have been when they came to see you, and you have to call 911 and you are in one state and the patient's in another state and there's no one around? Like, we don't always think about these things, but it's good to have those processes nailed down, because then you are less worried to have providers want to join your team, work on your team, and know what to do when they have that once in a year experience, but then they handled it beautifully. I want to pause for just a second to see if there are any specific Q&A that I can address. Otherwise, I can continue along.
Thank you, Matt. So there's microphones at some of the tables. If you can speak into the microphone so that actually the virtual participants can hear as well, and as also our main microphone here is also in the owl. And also, Matt, if you want to chat, I think Joe McMenamin had a comment or question in the chat as well. that I saw coming in. So if you can, I don't know if you can see the chat, otherwise I can read
Oh,
it
yeah.
out.
No, it's a good starting point. Thanks, Joe. So, right, so when the patient...
Matt, before we go there, there was actually a gentleman that walked up to a microphone.
Oh, sorry. Go ahead, please.
Is the microphone on? If it's not, if you could come up here, or just because we've got the microphone here that's going to pick up the sound. So we'll take the question in the room here first, Matt. And we're going to, hopefully the owl is going to reorient. That is working. Okay, wonderful.
Hey, Dr. Feynman. Hi, Alfred Atonda, Wilmington, Delaware. Just had a quick question. Earlier, you had talked about the quadruple aim when you talked about provider satisfaction. And, you know, one of the roles that I have, other than being a regular physician, is the director of physician well-being at our hospital. And, you know, we often struggle with, when we roll out new initiatives to our fellow physicians, how do we ensure that we have the, you know, end user experience at the top priority of the goal of whatever endeavor it is. So, and we have telemedicine at our institution as well, but, you know, there are lots of other innovative things that we like to deploy. Do you have any thoughts or tips, tricks, algorithms, white papers, anything that could be like a checklist of things that one should think about prior to rolling things out for physicians to ensure that, you know, their user experience is optimized?
No, that's a great question, actually, because almost every paper that I read about these days, and from personal, anecdotally, from experience, it's all been reactive. So how to frame the best answer to you from the experience I've had and what to do. Much of it is I guess, the twofold. I think part of it is when you're going to be selecting an EHR platform that has to marry with a telehealth platform, that you need physician champions, whether it be departmental or institute level, who sit at and help with that decision making, because they're going to understand their own clinicians, you know, better maybe than anyone else, to be able to provide some insight. But they need to sort of have a tactile feel of what it's like. And by that I mean, we did surveys when we were using like 5 different telehealth platforms, all for ambulatory, because this was during COVID when nothing was working effectively, and we were trying everything, and we kept getting survey after survey that said this piece of this one was great, this piece of this one was great. Get a bit of all these ones and find one that has all this, and then you'll make clinicians happy, because when they have the downtime where the tech goes out on this one, but the video of this one and the picture of this one, then we're ideally happy. And of course, we never could get there. And by the time we settled on it, you know, things improved. So I think that governance piece to sort of like do user acceptance testing and seeing, hey, these are the 3 or 4 places that we want to put this in play, and what disruption is this going to have to your usual workflows, like hybrid care versus, you know, carve out care, sort of the Swiss cheese versus block cheese of approach that I think Christian has talked about. You know, those little items, if you do those in advance, there's much more likelihood that you're going to see provider adoption rates be better than just simply saying things that happen to us, which is you need to put this many slots into your schedule every day, every provider, because we need to meet a bottom line number of X virtual visits across the board. Then it's just going to be flat. It's just not going to work.
Thank you.
And Matt, if you could read out the question. Okay.
Yeah.
Okay. If you could read out.
Yeah. So the first question was, when you have your patient jump to evaluate the abdomen and you want to check for wincing, what do you tell the patient about how to position his camera? And ironically, you can see I'm looking over on my other screen, just what I spoke to about website manner. So it all depends on two things. One, if the patient is by themselves versus if they have like a facilitator or a loved one with them, and then the device that they're using. So by that I mean, if they have a camera like I do, a webcam, they can sort of tilt the camera down, or I will have them back up enough so I can actually see them jump up and down because I want to make sure their feet clear the ground enough, because if they just pretend to jump and not do much, I recognize that some of my elderly patients are at risk of falling, so I don't want to push them too much on this. But the other part is, if there is, a caregiver with them, I will have them, if it's a smartphone or a tablet, I'll have them just reverse the camera and aim it, downwards like this, so I can sort of see them from sort of, belly button down, that area, and then have them, if they need someone to hold them, I will have them, lend an arm to someone and have them do a little bit of a jump. So it's all degrees of, who you need to examine under what circumstances, and then what their mobility is before they take that leap, because the last thing I want to do is send someone to the ER for a broken hip because I was trying to assess their abdominal pain. That doesn't look good for me. The other...
We have another question.
Yeah, comment as distinct from a question. If you prepare a telemedicine handbook or a set of clinical guidelines or both, write them with the knowledge that eventually your litigation adversary will obtain copies, read them carefully, and use them in your cross-examination. Yes, well said. It is true that that hat has to be worn when you're providing that. It's a difficult challenge but at the same time, we have handbooks that are in the clinic for in-clinic how you handle all these things anyways. So these are not so much of a carve out from what we're doing anyways. These are sort of what I would call policies and procedures. And these are sort of standards of care. And admittedly, yes, they're a little bit different because we are writing them for ourselves. But at the same time, if we create these and we adhere to them and we follow them, I would challenge that these may be better than if I have 20 different providers treating the same condition 20 different ways, when there should be sort of one single approach with one or two, first line therapy, second line therapy, and antibiotic concordance, when that's not happening without there being guidance. So I get it. Another question: are you aware of what extent?
We have another question in the room here.
Oh, I'm sorry. Go ahead.
Matt, this is Frank Slice from Jefferson Health. Nice presentation. When you're talking about quality in the education and getting your providers up to speed, where's the intersect on what your KPIs are in terms of quality, as far as people following through on what it is that you're teaching them, and then what the impact is, right? So, I mean, we talk a lot about educating people, and they check the box, they clicked it, they may or may not be competent, but where are you seeing the impact on quality for, we can certainly see over the years, right? It looked a lot different 5-8 years ago than it does, right before COVID and right after. Just curious if you have, any thoughts or data on, where you've driven that.
So fantastic question. I don't want to duck the answer, but the last remaining slides speak a little bit more to the process, and I want to highlight it, and I hope it should answer your question, and I'll make sure to circle back specifically. But KPIs are key in this, and I will highlight some specifics of what I do, but I have about 5 slides that are specifics. I did not get to the last piece after this pause was to kind of finish up with some of the approaches to quality. So I'll get to that in just a moment, if that's okay.
Perfect. Right, do you want to take the last question?
The last question from Craig Bromley was, are you aware to what extent performing a virtual physical exam is being incorporated into standard curriculum in medical schools? So the answer to that now is, compared to pre-COVID, both the AAMC for medical schools and the ACGME for residencies, etc., all now have made it sort of an important component that moving forward, there's actually some criteria around how much. I can't, if you're going to challenge to be how much of the curriculum is going to be telehealth inclusive. It is, the good news is it is more than 0, which it was pre-COVID. So they're moving in the direction of understanding that it needs to be a comprehensive aspect, that teaching the telehealth, clinicians of the future needs to be done there. in that aspect. I also understand that both in the PA schools and the nurse practitioner schools that it's being built into the curricula there as well. To what degree and what measures and metrics, I've started to see a little bit under the hood, but I haven't, I know those conversations are starting to happen. And I'm sorry, it's just sort of a high level answer. I just am starting to see it sort of be borne out in more detail. But great question. So let me.
Christian, I got one more. Hey, sorry, Steve North from Eleanor Health, and we face two workflow challenges in our practice in the virtual visit, and I wanted to get your thoughts and others' thoughts on how you handle these. The first is the no-show. In my clinic practice, I have the ability to, when I'm in a bricks and mortar building, I do something else. I work in another patient. I start the next patient earlier. I don't have that luxury in the virtual environment. So I'd like your thoughts on that. The second is the checkout process, where no longer does the patient go from the exam room with me past the desk where they can say, oh, and by the way, I forgot to ask the doctor for my refill on my X. Or making that follow-up appointment. How have you solved that issue in your group?
Yeah, great. So let me take the first one, the second part first. So the checkout process, it can be built differently depending on the virtual experience of how you want to do this, or just the workflow within your practice. Meaning, some actually have a telepresenter in the available before and or after, so they can actually do sort of a warm handoff to their own team. So that is saying stay in the room, and they have a nurse or a MA or someone come in to sort of make sure any additional thoughts around the follow-up is done. Some find that helpful. Some just sort of end the visit and then use the EMR tools to use the checkout, saying they send a note to their scheduling team electronically saying, please schedule Mrs. Jones for a 3-month follow-up. Please schedule with cardiology for an echo. Please do this, please do that. And it's all done asynchronously. It doesn't get around by the way, as the patient's walking out the door. I have found, for good or for bad, the secure patient portal, we were using Epic MyChart messages. The escalation of MyChart messages, went up over time as patients were using it as a tool to just say, hey, I don't really need a refill of my medication. I don't have a non-specific thing, but I forgot to ask you about this. And it ends up being a little bit more workload for the providers. We actually entertain doing asynchronous, asynchronous care as its own visit when patients started to give us diatribes of their, by the way, follow-ups ended up being longer than the visit itself. But that was often the only way the patients could follow up with us with that piece. So checkouts, I found that, in internal medicine and primary care, I had a great working relationship with my scheduling team. So I would send staff messages, e-messages. I would use the tools within the EMR. Whereas neurology, they actually had a presenter come back into the room and make sure that there was no additional items and that they had it done by warm handoff. So some of that depends. The no-show piece is tough. Ophthalmology and orthopedics and others actually double booked some of the areas because they knew that the no-show rate was so high. And depending on the insurance type, if it were regrettably certain insurance types were more likely to no-show than others. And this was done by just sort of metric analysis and data mining, that if it was this commercial payer on your schedule or this payer unlikely or this patient, so you would look ahead to your schedule or have your team look ahead and say, oh yeah, Mrs. Jones always no-shows, so I'm going to double book. This is not, this is again reactive process. There's no simple AI tools yet that I've seen to handle the no-show easily. Many of the virtual visit platforms that I worked with allowed you to say, hey, you know what, this is the 9 o'clock no-show, but I have a 9:20 appointment. I can get the 9:20 in now if they're available, and I could move my schedule around, especially in primary care. Notoriously, there were a couple of patients I needed to squeeze in somewhere, and so I would move the schedule around during the day, and it would be a little bit fluid, and I would try and squeeze someone in somewhere where someone decided to no-show. Again, this was a one-off solutions, because the solutions that worked across primary care and pediatrics worked fairly well across us internally. But again, subspecialty like to work it differently. They often said, "Oh yeah, we can double book into 4 slots per day, and we'll just double book with the expectation there'll be no shows." It's a hard thing to consider, and I guess it comes back to the apples and oranges comparison. If your no-show rate in brick and mortar is 8% or 5%, and virtual it's 3%, which I found it to be lower in general, then you want to make that number even lower, but you're still overall dealing with a lower percentage. If you're finding the opposite to be true, then it starts to be on you to figure out, maybe there's a pattern of where the no-shows are coming. Is it time of day, use case that we're selecting, or maybe insurer or other reasons, or maybe it's the self-pay. And then maybe you can make some better choices around how to optimize those slots. But great question.
Great questions. Thank you very much. Again, Matt can stay online here as well after the session, but I want to make sure that we end on time. Matt has another 5 slides here, so why don't you take home, and then again, people can still stay in the room here and do a little video chat here one-on-one with Matt afterwards as well.
Absolutely. So getting to the quality piece, so we do care about quality. It sort of adds that final element, especially for clinicians who think about it both on the education side and on the fact that many sort of shy away from national telemedicine meetings and others because they feel it's sometimes more vendor specific than it is society driven, and we're often, well, what does the evidence say and how do I get to that? And so there are numerous approaches to quality, which I'm a firm believer in. NQF back 5 years ago and last year came up with areas to focus on, and these were sort of re-highlighted again. And they're around things like access to care, making sure it's affordable and available, thinking about effectiveness, about what you're doing, both technical effectiveness of the solution that you deliver, clinical effectiveness, and operational effectiveness. And that experience, both for providers, for caregivers, for everyone, and figuring out ways that you can measure it. If you are thinking about measurement tools, some things we think about are the NPS scores that we use, which are done immediately post-visit. They can be a great insight into where there might be challenges and limitations. And then some of the impacts on cost, both to your system internally and to the patient and to the payer. And then you can build competencies. I looked at it, at least at Cleveland Clinic. One of the areas that we did about building this was on education and training, coming up with the technology, the platform, the proper onboarding to make sure that it was consistent, that there was standardized sort of videos that we could show for website manner and for how to handle some of the tech challenges, physical examination from neuro and musculoskeletal to everything head and neck and upper respiratory, making sure you have documentation elements. If you're going to collect documentation pieces like smart data elements that you pull from your EMR, that then you have this feedback loop, which I'll show in a slide in a second. And then making sure that you can standardize some of this and have a team to review it with champions that can give you feedback, not just from telehealth, but from maybe pharmacy, infectious disease, and other areas. Just in the interest of time, we provide these links to our team as we onboard them around, and some of these are 3 minutes, some of these are from national, others, some like from American Academy of Neurology is in 3 minutes, how to do a basic neurology exam. And some of these were created for ourselves. We worked with American Well at the time of how the visit would work to make sure that they were efficient and comfortable. Other tips and tricks for virtual visits to make sure that they were comfortable with those. And then things that you should teach your providers, regardless whether they are in the office or at home, about empathy. Like, how do you learn empathy? How can you talk to the patient and listen to the patient and echo back what they're asking you and making sure you've heard them and answered all their questions in a certain amount of time, and how to communicate effectively. And these are available. If the link doesn't work in the presentation itself, you can just copy the link into your web browser, and it will take you to the site. But this hopefully will answer the question that was asked from Jefferson. So, we take things at the patient at the center here, and you take your telehealth guidelines, evidence-based practice, you build templates. We have automated QA reports that build out things like ICD-10 codes against age, against, thou shalt nots, for example. Thou shalt not diagnose and treat otitis media via telehealth unless you can see the tympanic membrane. So if I see otitis media as a diagnosis, then I get with the provider and make sure that I can challenge and discuss and teach with them why are they, how are they possibly making that diagnosis without visualization of the TM. And that comes back to the audit and feedback and building out your guidelines. So we would pull data elements out of the EMR around things like, if you want to make a diagnosis of sinusitis, you need fever, double worsening, duration of symptoms, and we would all have drop downs that would be effective to the diagnosis, along with concordance to guidelines for antibiotics. Plus, the providers were all aware that their first 10 adult charts, their first 10 pediatric charts were all going to be audited when they started, and then a certain interval, 5% of all charts each month, would be audited with exactly this thing in mind, plus any of these variables, ICD codes against conditions that should not be treated, bronchitis with the use of antibiotics, for example. So we could take ICD codes against NDC codes. NDC is what you would get for any prescription, has a code associated with it. So we could pull from the EMR, and we would know what providers were more likely prescribing antibiotics routinely, which ones were less. And we met with them, and initially it was blinded. Eventually the group had competition in mind, like, I want to prescribe antibiotics less frequently than I've done before. So there was some internal competition that was designed. And so by having this feedback loop and sharing this, it allowed us to provide some benchmarking, improvement in our gaps, and allow for a better experience for the team. And actually, we were doing better at the end in 2021 than our cohorts in primary care, ambulatory care, walk-ins, urgent care, and ER. And so with that, just to wrap up, in the interest of I'm over a couple of minutes, I apologize. I had hoped to sort of overview virtual health, give you some tools to build a successful program, some tips and tricks around virtual visits and quality. And with that was the alignment with governance, creating a handbook, creating your guidelines, and providing that quality framework that you can use. And when you put those things together, your programs will create value for both your providers, clinicians, and your organization at large. Thank you very much for the opportunity. And as Christian alluded to, I'll be happy to hang around here and chat with anyone if anyone has any additional questions. Thank you.
All right, great. Thank you very much.